Alberto, you can place your first slide.
My first slide?
Yes.
Okay.
Because we need 3 minutes, then you can go out. Just please the first slide.
So I have to share the screen.
Good. It's 5, Dr. Ali. Let's go.
Yes.
Hey.
Okay.
I
Just have to see the picture of for me.
okay.
It's 5, Dr. Ali. Let's go.
Yes.
Hi. Hi, Dr. Ali.
Hi.
Can you hear me?
Hello, everybody. Yes, sure, I can hear you. Yes. Just.
Yes. Hi. Hi, Dr. Ali.
Hello.
Hello, everybody.
Yes.
Can hear you.
I think you have to mute your mobile, Ali, or anyone.
To Bashar, mute الموبايل. Mobile.
Because we are hearing the live also from your side. How are you,
Yes.
Muhammad?
He's
Hi,
not.
Alberto.
Hey.
How are you?
Let's go.
Okay.
Yes,
You're ready.
Quilla, I have to shift to my picture, Quilla. Yes.
يلا دكتور علي.
From my side مين يتحكم بالشاشة؟ اللي يتحكم بالشاشة كويلا تتحكم.
Okay, you are on the screen. Go ahead.
Okay. Hello everybody. Hello audience. Hello dentist. Today we have very special day. It's different from all the webinars. Today is the 44 webinar for Woodpecker. It's something incredible to have a 44 webinars in the coronavirus quarantine. But today is much different because we have not just a one speaker. We have three speakers, three very well-known speakers all around the world. They will talk about a very, very interesting subject, the subject to any dentist who is dealing with root canal treatment. He's so afraid from the fracture files inside the canal. And when this happened, the dentist feel fever in his body, and it's like a nightmare. And he don't know what to do, how to solve this problem. So today our speakers, they will try to solve this delusion and to give us the etiologies and the causes and how to solve this problem and how to avoid it. So today we have three speakers. The first one is the boss, Dr. Mohammed Hammo, who got a private clinic in Jordan. Everyone know him very well. And Dr. Alberto Dagna from Italy, and a special endodontist. And he is an adjunct professor at Pavia University. And also our lovely dentist with the very nice smile, Dr. Talal Nahlawi from Syria. He is an associate professor in the private university, Syrian private university. And me, and Dr. Ali Saad Abu Naila from Iraq. I am a PhD student in the dentist, and I'll just act as a moderator. The discussion will be got three parts. The first part, Dr. Alberto Dagna will tell us about the causes, the etiology, and how to prevent or avoid the fracture file to happen, and then show us his cases and how deal with this problem. Then we have Dr. Mohammed Hammo. He will tell us about bypassing one of the solutions for the fracture file, bypassing the fracture file, and also shows his cases. Then Dr. Talal, who is dealing with the removal of the fracture file, then also shows his cases. After that, we have time to receive your questions, and we hope our speakers can reply most of your questions. So now we will start. We'll start with Dr. Alberto Dagna from Italy to tell us about the causes and how to avoid and shows his cases. Please, Dr. Alberto, you can start.
Thank you so much. Thank you for the kind words. Welcome all. Hello all. Good afternoon, or better, here in Italy, is afternoon. I don't know the local time of everyone, but I'm very honored and proud to be there to share with you my opinion, my experience, and to discuss with colleagues, and not only colleagues, but mainly friends of mine. I will start speaking about the causes and the etiology of the fracture of a file inside the root canal, and I will discuss about the strategies to prevent the fracture of a file, of an IT file inside the root canal. The first question is why we can break a file inside the canal. We have so many causes. There are causes related to the anatomy of the tooth, to the endodontic anatomy. There are some causes related to the operation protocols, to the files, and to the operator. And analyzing each one of these causes, we can adopt strategies or solutions to prevent or to avoid the fracture, the separation of a file inside the root canal, because we don't want to leave a broken file inside the root canal. So we have to spend much more time to remove it or to bypass it according to the clinical situation. And we have lots and lots of articles in literature regarding the fracture, the causes, the analysis of the etiology of the fracture inside the root canal, and the strategies to prevent it in order to favor the best result for each one in endodontic therapy. For sure, endodontic anatomy is one of the main topic related to the fracture of root canal, because we have to consider each kind of variation we can find inside the root canal when we do the shaping and we do a root canal treatment. We have to consider the diameter of the root canal. We have to consider the curvature of each root canal, and for the curvature we have to evaluate the radius and the value of this curvature. And moreover, we have to consider the hardness of the dentin, because each file have to shape, to cut the dentin, and each anatomical variations like confluences of the canals. So when we have to shape a root canal, we can find a lot of difficulties to reach the working length and to reach the apical third. For sure, canal curvature is the main risk factor we can find when we treat a root canal, because curved canals are considered the main causes for stresses of the file. When a file is rotating or reciprocating inside a root canal meet a curvature, the file tend to maintain that curvature, and the nickel titanium alloy is stressed by compression inside the curvature and traction outside the curvature. And when the elastic limit of the alloy is exceeded, the file can separate inside of the root canal. So for this reason, in these years, the nickel titanium file has been evolved, and the evolution by manufacturers has the aim to make each nickel titanium file more performant. So manufacturers introduced some post-treatment procedures to increase the resistance of the file. One of these procedures is the electropolishing. Is a procedure made to reduce the irregularities of the surface and to reduce the cracks on the surface of the alloy. This procedure is helpful in increasing the corrosion resistance of the file and to increasing the resistance of the file inside the root canal. Moreover, many manufacturers introduced the heat treatment of the alloy. Heat treatment is a novel procedure that improves the resistance of the file. So we have today many modern files subjected to electropolishing, heat treatment, and other procedures that increase the resistance inside the root canal. So when we have to choose a file, the ideal condition is to choose a modern file, a last generation file. Many files on the market are available in a new martensitic phase, in a new martensitic alloy that is super elastic, is more resistant, more flexible, and more plastic, so is more resistant inside the root canal. And another consideration about the geometry and the instrument design is regarding the cross-section, because the file have to find the right compromise between the cutting ability and the flexibility and the maintenance of inner core, of a resistant inner core. Today, the tendency of the market and of the manufacturer is to produce asymmetrical cross-section files, so files with some primary blades made to cut the dentin and other secondary blades that theoretically don't contact the dentin walls, and reduce the friction of the file inside the root canal and give much more free space for debris elimination. So that's another reason why we have to choose modern nickel titanium systems, because the modern nickel titanium systems are more reliable and more resistant to the stresses inside a root canal. And also we have to evaluate, to consider the size and the taper of the files, because every time we increase the diameter or the taper or both inside of the root canal, the stiffness of the file is increasing. So if we choose a bigger instrument for size, for apical tip, for the size of the apical tip or for taper, we have to consider that the file is more resistant to flexural fatigue, more resistant to torsional fatigue, but less resistant to flexural fatigue due to its stiffness. And on the other end, when we choose a small file, we have to consider that a small file is more flexible, so is more resistant to the torsional to the flexural fatigue, but less resistant to torsional failure. So we have to choose between the right compromise between the dimension of the file. We will prefer small files for the initial preparation, the initial negotiation of the file, and then we have to increase the diameter of the taper according to the root canal anatomy without exceeding the dimension of the file, because we don't want to expose the file to the risk of separation inside the root canal. And we have to respect many operating protocols. Literature is according on the operator skill and experience as a crucial factor in preventing the separation inside the root canal. But we have to modulate the pressure of the file inside the root canal. Many authors advise brushing and packing motion of the file inside the root canal, and many authors, many articles shown that the crown down technique is more preventing than other techniques and reduce the risk of separation, because each file open the canal for the subsequent file. So we have to respect the protocols, the sequences of the file, and we have every time to work inside the root canal in presence of irrigating solution, because the liquids inside the root canal can lubricate the file and can reduce the friction along the dentinal walls. And the importance of irrigating solution is also to remove debris produced during the shaping. You can see in that images the big amount of small layer of dentinal chips and debris produced by the file. And these debris have to be removed along the dentinal walls and have to be removed between the blades of the file in order to reduce the friction inside the canal. We have also to consider as I told you before, the diameter of the canal. All the small diameter canals are cause of torsional stresses. This means that when the root canal is very narrow, is very tight, the friction of the file moving inside the root canal is very high. And we can have the risk of blockage inside the root canal. That's why many authors in the past and also today are showing the importance, the real importance of a preliminary shaping of the root canal, of creating a pre-enlargement of the canal to create a glide path. I remember every time the words of Arnaldo Castellucci. I remember he told that a root canal have to be considered as a bobsleigh track, where the nickel titanium file is like a bobsleigh. We have to drive it inside the root canal without pressure, without any force. We have to only to direct it inside the root canal without pushing it, without stressing it, making it free to reach the working length. And that's why we have to create every time an adequate pre-flaring, pre-enlargement of the canal to avoid the blockage of the tip of the file. Each nickel titanium file is made with a non-cutting edge, non-cutting tip that have to be free to rotate inside the root canal. If the tip of the file block inside the canal, we can have the risk of a taper lock, a phenomenon that block part of the file, the apical part of the file, while the remaining portion of the file is continuing to rotate. And this can stress the file, it can exceed the elastic limit of the file, and sometimes, or in many cases, the taper lock of the file is the cause of torsional stresses that may break, may cause the breakage of the file inside the canal. So we have to pre-enlarge the canal with the stainless steel and very small end files. And since the last years, we have at disposal also dedicated files for the pre-flaring. Files with small diameter and small taper that are made for pre-enlargement of the canal, but remembering that these small files are very flexible inside the root canal, and they create a pre-enlargement of the root canal. In this case, for example, the first one is on the left is a file made for the pre-enlargement with a 3% taper and a tip with 14 diameter. This file created, when reach the working length, creates the ideal condition for a bigger file, like a 25 tip and 6% taper, to rotate inside the root canal, reducing the risk of taper lock till the last millimeters of the canal. As I told you, each file is made to move inside the root canal. The speed of rotation is considered another cause of stress inside the root canal. Many files can fracture inside the root canal due to an incorrect rotation speed. We have to consider that if the file rotate or move inside the canal with a very low speed or a too low speed, the file is under risk of high friction inside the root canal. If the speed is too high, we have the opposite risk of exceed the limit, the resistance limit of the file. So we have at disposal electronical handpieces devices in which we can set the parameters of rotation, of speed and torque, respecting manufacturer's instructions. So we have to respect the limit, the minimum or the maximum limit indicated by the manufacturer of the file, and to set these values on the handpiece. Many handpieces have preset programs for each kind of file. And we have also to respect the torque, because when we reach too high values of torque, some handpieces are able to do a contra-rotation of the file in order to reduce the stress of the file. Some modern handpieces, electronic handpieces, have also the ability to convert from continuous rotation to reciprocation according to the stress of the file inside the root canal. So we have to consider all these parameters as a cause of stress of the file. We can control with our eyes and our magnification system the stress of the file. These images are images of grit unwindings, grit deformation of the files. Some alloys are made to favor this kind of deformation, and this kind of files help us in control the stresses, and when we verify a deformation, like in this case, we can discard the files. But in many cases, we have to consider not only macroscopic deformation or macroscopic wear of the alloy. We have to consider that the nickel titanium alloy can undergo to microscopic deformations that we cannot see. So we have to control the use of the file, and we have to discard the file when the moment of discarding is reached. Considering that when we reuse a file, we subject these files to chemical agents, cleaning a disinfecting solution that may affect the integrity of the surface of this file. We have, I found in literature some articles speaking about this topic. Many authors underline that 10 times of cleaning of a file inside a chemical agent can increase the risk of corrosion and of fracture inside the root canal because of modification of the alloy. In the same time, thermal stresses inside the autoclave due to sterilization cycle can damage the file, can increase in the irregularities of surface, can modify the topography of the file and the chemical composition of nickel titanium files. So each time we sterilize a nickel titanium instrument inside the root canal, we can reduce its resistance to the stresses. So we have to control the number of sterilization cycles. We have to control the number of reuse inside a root canal, modulating the number of reuse to the difficulties we encounter during a root canal treatment. Or, if you want, we can choose between modern single-use files, nickel titanium files, made with modern nickel titanium alloys. If we don't do that, we can find cases like this. This is a case I treated many years ago, in which you can find an entire nickel titanium broken inside a straight canal. Probably the colleague who treated this tooth didn't do a correct pre-enlargement of the canal, didn't evaluate the hardness of the dentin, even if the canal is completely straight, and broke this old ProTaper universal file, probably due to the taper lock inside the canal. Today, we want to prevent the fracture, so I can put your attention to these interesting articles I cited before in my presentation that give us some advices to prevent the fracture inside the canal. So we can respect some laws, some protocols to prevent the separation of a file. We can find many articles of authors like this one of a friend of mine, in which you can find some advices how to do to prevent the file separation. But file separation happens. we can break some files of us inside the root canal, or we have to retreat some tooth with the previous broken files inside the root canal. So just to conclude, I want to show the cover clinical case, the clinical case I put in the cover of this short presentation. And I want to share with you what I did for this lower second molar. Just for
Dr. Alberto, Dr. Alberto, please. I hope your case will be slightly in a small time, because we have multiple cases to show for Dr. Talal and Dr. Mohammed.
Okay,
so please,
I finished it.
I have
only this case.
Yes, yes, please.
Okay.
Thank you.
Do I have to finish right now, or can I present this case?
No. You can show us your case, but just
okay.
Time is going out.
Just 1 minute, no more of presentation.
Okay. Thank you.
Okay, this is a second molar with an original anatomy in which I find this broken file in the middle third of the root. The first step is to reopen the access cavity and to remove all the filling materials, and with the ultrasonic tips, in this case a short tip made to clean the coronal portion of the tooth and of the canal, I remove all the old material. I go quick, I clean all the material, and I discovered the head of the broken file. This is the floor of this tooth at the middle third of the root, where there was a trifurcation of canals, and in one of these canals the head, the fragment was broken. I cleaned, I disinfected, and after more than 1 hour of work inside this canal, I scouted the canals, and I put a temporary filling, because the patient was a little bit tired, me too, and I had no more time at disposal for concluding this treatment. So in the second visit, I restart the treatment, putting my attention to the removal of this instrument, and with a long ultrasonic tip with a small apical diameter, I vibrated the head of the file and mobilized the file, since the file moved away, with no necessities of specific kits for instrument removal, because the fragment was blocked into a straight portion of the canal, and I was able to move it, to mobilize it, and to remove it coronally. And then I concluded the ordinary treatment with shaping, cleaning, and three-dimensional obturation. So to conclude my presentation, I have this question. Do we have today a scientific, perfect method to avoid the fracture of nickel titanium instruments inside the root canal? Yes, don't be scared by my answer. We can do it. We can avoid the fracture of a file only doing not endodontics. If we do endodontics, we are exposed to the risk of a breakage of a file, or we are exposed to the risk of finding into a retreatment case a fragment broken inside the root canal. So we have many colleagues, many literatures, many articles showing how to manage separated files inside the root canal. But we know, and we know that what is the best solution probably is to remove it. But in many cases, we are not able to remove a fragment from a root canal. So we have two choices. But
thank you, Dr. Alberto, for very nice presentation.
To the colleague,
yes.
The time to speak about two choices: bypass and removal of the files.
Okay, thank you, Dr. Alberto, so much for your nice presentation, for nice informations. Now I will go to our guest, Dr. Hammo. What's your idea? Do you have another notes, another solutions about the etiology and the precautions? Can you add something to Dr. Alberto? Yes, please, Dr. Hammo.
Yes. Thank you, Dr. Ali. Thank you, Dr. Alberto.
Welcome.
Yes. So my topic will be about the management of broken files, and I will talk about bypassing technique, and Dr. Talal will talk about the removal part. Let me remind you before starting, the goal is not to remove or bypass. The goal is to clean, shape, and obturate the portion of the root canal apical to the broken instrument. So our goal is to reach to the end of the canal and to clean the whole canal. Because of this, the treatment can be successful either by removing the separated instrument or bypassing separated instrument. Let's talk a minute about removal of separated instrument, and Dr. Talal will go deeply in this subject. But let me remind you, when we talk about removal of separated instrument, we are talking about what we call microsonic technique. And this micro, it means we need the microscope, and the advent of microscope will facilitate primarily visual guided. So with the microscope, we can see where is the broken instrument. And microsonic, we need ultrasonic tip, which becomes an integral part to remove separated instrument. So when you decide to remove a broken instrument, you need two things. You need to see it with the magnification device. You need to move it with the ultrasonic tip. For me, the potential to remove a separated instrument is directly related to visibility. So my decision to remove or not to remove a broken instrument depends mainly on visibility, whether the fragment can be visualized or not. So visibility depends on the location of separated instrument. So remember, when you want to remove an instrument, you should see the broken instrument before placing your ultrasonic tip. Because if the separated instrument extends into the straight coronal portion of the canal, retrieval is simple and easy. So like this case here, this broken instrument in a straight line, so we can see it, we can shake it with the ultrasonic tip, and we can remove it. And as you can see, we will fill the canal, and you can see the follow-up after 80. But what if the entire broken instrument is apical to the canal curvature? Then, like this case here, the broken instrument is not in the straight line, it is apically, or like this here, it's apically, or like this, we could not see it. When you could not see the broken instrument, removal will not be recommended, because attempts to do so could lead to a much higher rate of iatrogenic complication. Let me show you this case. Here, this is the second molar, mandibular molar. And our colleague, he started to prepare the canal. Unfortunately, he did not make a proper access cavity. As Dr. Alberto said, he did not make a proper glide path. So the end was a breakage of the instrument. And let me tell you, every dentist might break an instrument. As long as you are working with a fine tools, you might break an instrument. The problem is, if you break an instrument, how you will deal with it. Let's apply what we talked about. And the rule was, if I could not see it, I should not use ultrasonic tip. If this instrument is invisible with the magnification, you should not use ultrasonic tip. Our colleague here, he was insisting to remove the broken instrument with the ultrasonic tip. So he started drilling without seeing where is it, and he removed part of this precious dentine. So you can see here, the broken instrument was not moving, but the dentine, a lot of dentine was removed. Unfortunately, our colleague, he did not stop to this point. He continued removing the dentine to remove the broken instrument, and unfortunately, the tooth was completely destroyed. You can see here, a lot of dentine was removed, perforation occurred, and unfortunately, this tooth is so difficult to be saved. So we lost the tooth because our colleague, he did not know the rule of removal of a broken instrument, the visibility. Another important thing, when you see the broken instrument, you should also think about the thickness of the dentine or the remaining dentine. So although if I can see the broken instrument, I have to think, is this tooth or root is narrow or not? Is there is enough dentine or not? So while removing instrument, you should take care of dentine. Like here, I'm not a hero because I removed a broken instrument. You are a hero if you preserve the structure of the tooth. So our colleague here, he removed the broken instrument, but unfortunately, he destroyed the tooth. You can see here, he removed a lot of precious dentine, and now the tooth is so brittle. Because of this, I like to add another important issue. While you are using ultrasonic tip, you should remember this ultrasonic tip might regenerate or generate heat. So use of ultrasonics can potentially generate enough heat to raise the temperature of the external root surface by 10 degrees or more. And temperature elevation of the periodontal ligament in excess of 10 degrees can cause damage to the attachment apparatus and might cause necrosis of the bone. So there is an alternative technique which does not require direct visibility to the fragment. So if I could not have a direct visibility, I will shift to another technique which is called bypass. And by the way, bypassing is a simple, easy, more conservative technique. This technique is for general dentists, which means we do not need high magnification, we do not need microscope, we do not need special tools. So I would like to share you how we will make this bypass and the rules of bypassing. A broken instrument can often be bypassed if the canal are oval or irregular in shape. So if the canal is oval, I will find a space between the canal wall and the broken instrument, and I can go through this space. And fortunately, all canals are oval in upper molars. Most of the canal are oval in lower molars. So let me show you how we will make the bypassing. This is an artificial tooth from Micromega, and you can see here, this is a broken instrument, and I want to tell you how we will bypass this broken instrument. So remember, bypassing, it's a manual game. That means it depends on the manual files. So let's go. First of all, I have to flare the coronal portion of the canal above the separated fragment. So I will use flaring files. In this case, I will use EndoFlare from Micromega. So let's see here. I will flare the entrance of the canal coronal to the broken instrument to enable me to have enough space. Then immediately I will irrigate with the sodium hypochlorite. So you can see here, this is the broken instrument, and this portion is flared and irrigated with sodium hypochlorite. The second step, I have to apply lubricant, and lubricant and chelator will facilitate bypassing. So here I have a broken fragment in this canal, so I will place lubricant. Now we will go to our hero of bypassing. I will take the K file number 10, pre-curve the K file number 10, and insert it inside the canal in a watch winding movement. This movement will act as a radar. It will detect a space between a broken file and the canal wall. And remember, I will depend on the K file number 10. There is no place for K file 6 or 8, just number 10. And with the K file, not here, not H file. So let's go. Here, I will take the K file number 10, pre-curve the K file number 10. Insert it inside the canal. Watch winding movement. I will keep watch winding till I reach to the end of the canal. Once I reach to the end of the canal, I will go in and out motion. And remember, we need K files, not K file. We need sometimes 3 or 5 or 10 K files, which means this is so logic, because once you bypass the broken instrument, your file will be distorted. So you have to replace it. So use several K files number 10. Once you progress deeply, I will check with the apex locator. Now I will insert K file and check with the apex locator. Here is the apex locator. Once the apex locator gives me 0, 0, this is my final destination. So this is the 0, 0 point. And this apex locator also from Woodpecker. This is now my 0, 0. Now I have to verify with the X-ray. So let's take X-ray to know where is my file reach. Now my file reach to the end of the canal. That means I am in the right way. Now I will keep working with the K file number 10 till it becomes super loose. And remember this word, super loose. So keep working with the K file till it becomes super loose. Next, irrigate with sodium hypochlorite. Next, now I will continue with the manual files because it's a manual game. I will go with the K file 15, then 20, then 25 till they become super loose. Between them, I will check the patency with the K file number 10. So let's go. This is the K file 15. Then I will keep working with 15. Then I will go with the 20. Then I will go with the 25. This is always a question from our colleague. Can we use rotary file after bypassing? Personally, I will use the heat-treated file. I will use a heat-treated file, 4% taper. In this case, I will use the two-shape file from Micromega. It's heat-treated. I will bypass after K file 25 till I reach to the end of the canal. So I will bypass. Then I will enlarge the canal with 4% heat-treated file. Then I will make my obturation. We have 3 scenarios in case of bypassing. First scenario, bypass and remove the fragment. So sometimes the K file is wedged between the flutes of the K file, the broken file, and the wall of the canal, and the segment might be retrieved. So like here, I have a broken file. So I will make my flaring, then K file number 10, bypass, then 15, then 20, then 25. Sometimes while I am bypassing and enlarge the canal, this fragment might jump, and then I will continue my cleaning and shaping. But remember, in multi-canals like molar, because there is a possibility of this file to be removed, we have to protect the other canals and prevent this fragment to enter inside the other canal. So what to do? I will place cotton pellet inside the exposed orifices in multi-canal. So here we will place a cotton pellet inside. Then I will deal with the broken file. I bypassed it, and while I was bypassing, it jumped, but it went to the cotton pellet, so it will not enter inside the other canals. Now I will continue cleaning, shaping, and obturation of these canals. So the most critical requirement here are determination and patience. And let me advise you, don't advise any patient that you will remove the broken file. You can tell him, I will try my best to bypass, but the broken instrument usually could not be removed, because our goal is not to remove. Our goal is to reach to the end of the canal, either by removing it or bypassing it. Let me show you this case here. This is a very interesting case. This is a broken instrument here, and I told the patient I could not remove the broken instrument, I will bypass it. So I enlarged the canal over this broken instrument, and while I was bypassing with K file number 10, 15, 20, the broken instrument was jumped. Then I continue cleaning my canals here, and as you can see here, it was in 2013. Let's see, after 1 year, then 2 years, then 4 years, you can see the great healing. Let's see the second scenario. The second scenario, if we bypass and could not remove the broken instrument, what to do? Enlarge the canal to a desired size for optimum debridement, then incorporate the broken instrument into the obturation. Bypassing the instrument and incorporating it into an obturation should also have no effect on the prognosis. So I will bypass here, then it was not removed. So what I will do, I will place my get-a-bear can near the broken instrument, and the broken instrument will be part of the final obturation. So let's see here, I have 1, 2 broken instruments. I bypassed them, but they were not removed. Fine, I will place my get-a-bear, and you can see the broken instruments are surrounded from the sides and down and up with the get-a-bear. And as I told you, this will not affect the success. Let's see here, in 2013, I bypassed the broken instrument here. Then after 25, it was not removed. So I will place the get-a-bear near it. And let's see this case after 6 years, healing occurred. Let's see here. I have broken instrument in the mesiobuccal canal. Let's see bypassing and obturation. And that was in 2010. Let's see the case after 9 years. We have complete healing. Let's see the third scenario. The third scenario, sometimes you could not bypass, you could not remove. So what to do? Do your best. Wait, give the tooth a chance, do the other canals as best as you can. Here, this broken file was broken at the apical part. I could not bypass, so it's better to leave it rather than to make perforation. So I will stop here and I will keep it under observation. So let's see this case after 1 year. Nothing happened. We will keep it under observation. Let's see this broken instrument in 2008. I could not remove, neither bypass. So I made the other canals as best as I can. I will stop here and let me see the prognosis after 11 years. You can see complete healing, nothing occurred. I have 1, 2, 3, 4 broken instruments. I could not remove them. So I bypassed, and then the obturation below. And the goal here is achieved because my goal is to reach to the end of the canal. So it was done here. So I have 2 home messages. my first home message, bypassing is for general dentists. Everyone can do it. It is a simple procedure. You need manual files, you need to be patient, and you have to have a lot of determination. So let's see here. I have 1, 2, 3, 4 broken instruments, and I believe we can do it. So let's remove the broken instrument from the straight line. As we said, we can remove it with ultrasonic tip, but those parts, I could not remove them. I will bypass them. So you can see them here. And let's see this case after how many years? 1 year, you can see the healing. Let me show you the second advice. Please don't give up. Do your best and believe in yourself, because you can do this. So let's see this case here. While bypassing, while treating this case, my colleague, he broke 1, 2, 3 instruments. He was trying to bypass, he made perforation. So he decided to take it out and make implant. But the patient refused, he came to me. So I told him, I will do my best. I could not promise you anything, but I would like to give the tooth another chance. So after 3 visits, I could bypass one of them. I could not bypass this one, and the perforation was sealed with the zinc oxide digenol here. Now let's see the follow-up after how many years? After 3 years, you can see here, complete healing, and we could save this tooth. So 2 advices. First, believe in yourself, you can do it. Second, don't give up, and I wish you the best. So let's see now the third type of management, which is removal with Dr. Talal. Thank you all.
Thank you, Dr. Hammo, for very nice presentation, very nice notes about bypassing. Now I will go to our beloved Dr. Talal Nahlawi. Dr. Talal Nahlawi, before starting your solution about the removal of the fracture instrument, I hope that you can give us some beneficial notes about the precautions and etiology of the fracture, simple notes, and about bypassing, how you can compare bypassing and the removal at your presentation, as you like. Please start, Dr. Talal Nahlawi.
Thank you, Ali. I hope you can hear me. Thank you very much. Thank you, Alberto. Thank you, Hammo. It was nice to be here. I think the main issue that is to have a debate and to discuss. It was nice. I have some questions for you, or some comments to add for Alberto, and also some questions and something to add for Hammo. My friend Alberto, I just want to add something related to the prevention, or the way you were dealing with the broken file. I believe you put a very nice, of course, it was very nice, informative. You listed almost all the factors, but I found one of them. I feel that because a lot of dentists, they can hear us now, and we can give them an advice, something related to the radio of the canal. And I believe the early curvature of the canal is very dangerous, and every dentist has to be aware of this. And for example, by incidence, Hammo put the first case of the dentist who broke a file, the long broken file in the molar, was, I think it was not due to the access, Muhammad. I believe that it was to the radio of the canal, the early curvature. And I give an advice for dentists. When they feel initial resistance at the coronal part, they have to be aware of any potential of file separation. So as you said, Alberto, and as you said, Muhammad, it's very important. So I want to emphasize, if you feel, for our dentist, if you feel any resistance in the just very beginning, please try to flare a good way your coronal part in order to minimize the early curvature and the radio of the canal, not to have any potential of a fracture. Alberto, this is what I wanted to add, but I have a question, or I have a note, please, for your clinical case. Can you hear me, Alberto? We can't hear you, Alberto. Ali, can you hear me, Ali?
Yes, sure. Very clear.
Muhammad, can you hear me?
Yes, of course. But before jumping, Talal, I think
maybe
the
Alberto is muted. He muted himself. Sorry. Please send him to the WhatsApp group that Alberto is muted. Okay.
Okay.
What I want to say, I think the secret words here for Alberto and for what we talk, if you don't want to break an instrument, be sure your glide path is super loose and smooth. Otherwise, you will face a lot of breakage.
Yes, but I want to emphasize that the early curvature is very dangerous because sometimes you use a new rotary files, but you inserted, you know, when you reach the full working length, the diameter of the file in the early curvature will be large. So the cyclic fatigue effect will be more on the file, so we may have any fracture.
So do you think if we, sorry.
No, I agree.
Yes, Dr. Alberto, please.
Okay, I agree with you, and I just want to underline that probably in my presentation I didn't mention the importance of access cavity. Mohammed talked about the correct access cavity to eliminate any interferences and to create the right access to orifices of the canal. So I didn't mention it, but it's a very important point to respect the opening of the access cavity.
If you allow me, Alberto, also regarding your clinical case of the lower premolar with the broken file, you did instrument first the canal, the patent canal first before trying to remove?
Yeah, I flared around the head of the fragment. I opened
for me, if I have the same scenario, I would prefer to try to remove the file first before flaring the other canal. Or if I flare the other canal, I would prefer to block it with something like what Dr. Hammo did in order not to jump for the broken file to be in the other canal. So I didn't get why you did the flaring for the other canal before trying to remove. I just want to learn from your side, what is the logic behind doing this?
I flared that canal a little bit around the head of the file because I remember it's a case of more than 6, 7, 8 years ago, but the file was very blocked inside the canal. So I enlarged the space to favor the vibration of the file and the contact with the ultrasonic tip.
Alberto, I have a question for you.
Yeah, I'm here.
This premolar has 3 canals, am I right?
The premolar?
This premolar has 3 canals, and those 3 canals have 2 exits, which means 2 canals are joining.
Yeah.
Am I right?
No, it was a molar, a second molar. You're speaking about the second, the molar.
No, the premolar, Alberto, the last case.
The last case was a molar, a second molar.
Oh, really?
Okay, so those are 3 canals and 2 exits, 2 foramen.
Yeah, right. Right.
Do you think if this is my case, I will not dare, you are so brave to place your ultrasonic tip down, because this will remove a lot of dentine. If this is my case, I will take combi. If I find this is 2 exit, I might leave it, and because it joins with the other canal. Do you think this will work also?
Probably yes, but in my personal opinion, I preferred to remove that fragment, because sometimes we cannot know the presence of lateral canals, of anastomosis, of collateral canals. So I prefer, when in this case, or in cases like this, if I can see the file, I can vibrate it, I prefer to remove to guarantee the better cleaning as possible.
I know you and Talal are instrument remover lovers.
Right.
Because of this, you insist to remove. You don't
Probably
like
I'm not so skilled. I'm not so skilled in bypassing the files. That's why I prefer to remove. When it's possible to remove. Okay.
Let's see your part, Talal. Then we can ask.
Okay. I think we have to shift, but I just want to finish with something, or before starting, because it was very nice presentation from your side, Muhammad. But regarding the example you put about the premolar, you said that the dentist tried to remove a broken file and he destroyed. Actually, the premolar was destroyed, but I don't believe that you can tell that it is the mistake of the technique. It's the mistake of the dentist. And I remember I remember one thing, Muhammad. This you put a post maybe 6 months before about this case, and you said that this is the result of one dentist after attending a broken file removal. Okay, and I remember well. And so let's hear my part and let's speak about this technique. Thank you very much, my friends. Thank you, Ali, and I hope that we will continue. Okay, very nice. Everyone can hear me. It's my pleasure. I hope that I will stick to the time. I will be having 15 to 20 minutes, not more, hopefully. I'll try to stick to the time. Thank you very much, my friends. Thank you, Good Baker, actually, company for inviting us for this nice debate. And also at the end of my presentation, we're gonna discuss more and more about this issue. We're gonna have more idea. Thank you, Dr. Ali, for moderating this session. And I hope that you find my presentation informative for you all. Okay, now I'm going to speak about the other treatment modality that was about the broken file removal. I believe, for me, that the removal of the broken file from inside the root canal will present us the best case scenario in terms of better debridement, in terms of better obturation of the root canal, in order to give us a better healing potential at the end. This is in general, and this is according to literature. But going more specific, and also like what Dr. Muhammad was saying, it is not a general rule, and we will not be able to deal with the situation every time the same case. So it is not good to do for a removal for every clinical cases, but we have to stick to the thing that was mentioned by Dr. Muhammad, that if we have a deep beyond the curvature, it's very important. We will not be able to see the broken file. It is not logic to try to remove it. Although I know some speakers or some my friends of mine, they will love to do this, like my friend Yushi Turushi. But for me, I don't dare to try to remove a broken file beyond the curvature, because I believe that I will destroy more than I can make something good. But on the other hand, and it's very important, when I can see the broken file, when it is in a straight portion of the canal, regardless of the location, my first choice will be removal. So we are all agree on the general guidelines of how to deal with the broken file. But maybe I disagree, because me and Hamu are speaking about the management. Maybe I disagree with something what is related to the bypass or removal. For example, this clinical case, and I have a deep broken file, it's beyond curvature. If I plan the treatment plan from the very beginning to remove this broken file, so I need to expose the dentine till this level, at least to expose 1 millimeter of the tip of the file in order to hold it, in order to activate it, whatever, to remove it. So I'm going to remove a considerable amount of the dentine. So I don't believe in these cases that we have to go for removal. Bypassing will be better, and especially the canal is wide, and we did an obturation in this case. But my presentation today is not going to be about bypass. I'm going to speak about the bypass limitation, because in Dr. Muhammad's presentation, he mentioned only the drawbacks of removal. He didn't mention the drawbacks of bypass. I'm going today to mention the drawbacks of bypass according to my opinion and according to my practice, in order to make a cost benefit for each case. So at the end of the day, I believe that we don't have to deal with all cases in one treatment scenario. We have to make a compromise. So in cases that is indicated for removal, I can see it, I can vibrate it, I have to go for removal rather than bypass. So you will tell me why. You go for bypass. Bypass is more safer. Bypass will minimize more tooth structure. I will give you some ideas, and we will discuss about this later. So one of the limitations, I believe, for bypass is the difficulty in a root canal preparation. And we have to admit that the more the coronal the broken file is, the longer the broken file is, the more the engagement with the rotary file, like you see After bypassing, we can go with rotary file, heat-treated file to instrument our root canal. But if we have a long broken file, if we have more coronal position of the broken file, that means we will have larger diameter for the rotary file to touch the broken file. And this will give us a potential for complication during the instrumentation. And another third thing that will minimize our sufficient enlargement of the root canal. We know all that we try to enlarge a root canal to a limit, not to enlarge too much in order not to remove tooth structure, but to be sufficient enough to provide us with sufficient circulation of the irrigation solution. So if we have a broken file and we don't want to have any complication during instrumenting beside this broken file, sometimes, I'm afraid, sometimes we will go for little or minimal instrumentation, and this will affect the amount of irrigant that will circulate in the apical area, which is very important for us to give us a good healing at the end. So this sometimes may lead, I'm not saying that 100%, with a skilled dentist like Hammo, like Alberto, like so many endodontists that are listening to us, I'm sure that they will do sufficient flaring, but I'm afraid that sometimes, like if an expert try to deal in a removal with an expert way, it will remove too much to structure, and also an expert way in bypassing, I'm afraid that we will gonna have a potential for this scenario. Let's see this case. A broken file, dentist while he is instrumenting, he had a broken file. This is the first broken file. It happens with us all at the apical part, lower molar, mesial, roots. This is the highest incidence of file separation in this area. He tried to bypass. He didn't manage well. He broke another one. So he tried to go from the other canal. They were joining because the two files, they touched it together. He broke a third one. So we can see that the presence of a broken file into the root canal will make some complication while during instrumentation. Another clinical case, while I was looking at this broken file, which was referred to me, I see this broken file. It was very clear, but I saw also a very tiny K file. And it was, I think, K file 6 and 8. And that's for that, I agree with my friend, Dr. Hammo. We don't have to shift for smaller files, because smaller files, when you bypass beside a larger broken file, sometimes they will break and you will complicate the case more and more. And this was the clinical scene for the distal root. I thought at the beginning I have one broken 2% file, but actually they were both two. And also look on the mesial root. The dentist broke a file, he tried to bypass, he broke another file. So we have to admit that we have to deal in this area after bypassing very carefully. It is not when you get a catch, when you will be lucky to get a catch. And by the way, not all times you will be able to get a catch. If you are lucky, or if you do the precaution that was suggested by my friend to enlarge, to activate, whatever, you have to pay attention. You have to pay attention very well for the bypass, because when you instrument beside the broken file, sometimes it will be dangerous and you will risk of additional fracture of the file. So we have now 4 broken files in this case. I removed the distal 2 broken file. I removed the mesial bypassing one, and I look here. I don't believe that I have to go for bypassing more, because if I have too much broken file, like what Dr. Muhammad, he's more skillful than me, he will be able to bypass 3-4 broken file. But I'm afraid that if I bypass too much broken file, I will increase the risk of having more obturation of the root canal with the broken file. So I don't need to have this. I removed the final one. I discovered that I have a very tiny one, a small broken file at the apical area. I removed it, but the very first or the end one, I will not, of course, be able to remove it, so I bypass. So this is the case before and after, and dealing with a clinical case with 5 broken files. This is one limitation of bypass. The other limitation is incomplete canal debridement. I believe 100%, of course, we have to clean the canal till we reach the portal of exit, which is at the end of the root canal. But it is not the same scenario in all cases. Sometimes we have portal of exit at the long, we have lateral canals. So it is not that only we have to go till the end. We can also have something. So if I have a long broken file, I don't prefer to bypass, because I believe if I did my best, I would not be able to clean what is beside the long broken file, especially if it is wide in diameter. So let's see this clinical case. This clinical case, when was referred to me, you can see we have a broken file at the apical area. So I think that, okay, we have a deep broken file. It is logic to go for bypass. But if you look closer, you will find something beside this broken file. And actually, it was another broken file. It was something happened, complication happened with the dentist. He broke a file, he tried to bypass, so he knows he broke a file. He tried to bypass, he broke another file, he decided to leave everything, put a screw and make a restoration and go for crown. But the patient keep having symptoms, so he was referred to me. So we have two broken files. This is one thing. Look closer. We have another thing that we can learn from this X-ray. If you look for the borders of the root and the borders of the BDL, you can see that we have space, lateral space. When I see this lateral space, I suspect in most of the cases that I may have lateral portal of exit. So now I have two broken files at the and I have wider BDL on the distal. So I'm suspecting another lateral canal here. Although this case is indicated for bypass, but here I have to shift for another treatment modality, which is removal. Especially that I'm dealing now with a palatal canal. And you know all that the palatal canal has good mass of tooth structure. And I was removing just a little bit palatally. And it was already enlarged because the dentist put a screw previous. So I removed the first one. I started to remove the bypassing one. And then I used the U file because the U file is very thin and will give you very nice, although this was palatal canal 24 millimeters, but I have to remove it. And then this is the canal after removal. And I gain an access so I can reach the end of the working legs. And this is the obturation. And I was right. You look for the apical area. There was a lateral canal. So this widening in the BDL refers to a lateral portal of exit. For me, I believe in that case, if I go for bypass, although it is indicated, it is in the apical third. If I go for bypass, I miss the chance to disinfect this area and the apical area, and to miss this chance to have obturation of the lateral canal. And as a gift, I have 3 portals of exit in the medial root. This is another issue. And the third limitation of bypass, I believe that also it will give me a difficulty in a root canal obturation. Not only debridement and instrumentation and the cleaning, but also difficulty in root canal obturation, especially with warm vertical obturation. Let's see this case. This is one very old case, was referred to me. The dentist wants me to manage this case. At that time, I was not practicing under microscope in that clinic. So no microscope was available. So I have to go for bypass, like my friend said. Of course, if I'm not expert, if I don't have the tools, don't please go for removal. Otherwise, you will destroy the root like what we see clinically. But at that case, I choose to go for bypass because I don't have microscope, and it's very old case. And for me, bypass was very easy. Why? Because you can see 2 aspects. We have to analyze each case we are seeing. This is 2% file. It is not 6%. It's not 4%. It's 2%, and the canal is wide. So the potential for having spaces is high. So it's good to go for bypass. I did the bypass. As you can see, I instrumented the canal. And then you can see what happened. The file pushed apically. Why? This is very important issue, because when you bypass a broken file and you instrument your root canal beside the bypassed broken file, you will gonna have space. If you do activation with ultrasonics, sometimes it will detach from the wall and it will be pushed. So now I am dealing with another location. Again, I repeated the protocol, I bypassed it again, and this is the conflict. And I believe I solved the problem. Let's go for obturation. I went for one vertical obturation, and guess what? Oops, the file went out. So the case was referred to me to solve the problem. I contributed to increase the suffering of the patient and the dentist. And why this mistake happened with me? Because I used a plugger, and the plugger pushed the broken file, which was loose, into the root canal. So also, it's very important to understand that obturation With a broken file, sometimes we'll push the broken file out of the apex. And of course, like my friend said, if you clean well, obturate and wait and see. And this is the case after 2 years, you can see that I have complete healing. And this is the same case after 7 years. Even the broken file went out of the root and I have complete healing. So it is related to the obturation and the cleaning of the area that we are dealing with. The fourth limitation of bypass is that sometimes we try to create or to find a gap between the walls of the canal and the broken file. But sometimes we will not be able. We have to admit that not all the cases are bypassable. I believe 100%. And so many endodontists, they are listening to me now, and I believe that they are moving their head, they agree with me. Not all the cases, they are bypassable, okay? But sometimes we insist. And I know that we are using aggressive files sometimes like B-Finder, like C+ file, like C files with some more aggressive tips in order to create a space around the broken file. But sometimes we will make transportation rather than making a bypassing. And I will list a case of mine. I did a transportation. This is an apical third. I will not think of removing this file. I will go for bypass because it is in the apical third, as you can see, in order to clean well. This 1 millimeter at the end. But what happened is the following. I was successful to bypass a broken file radiographically. I bypassed it on the X-ray. But actually, if you look in closer, you can understand that I made a transportation. It is not a bypass. So also, this is a very important risk of bypassing that we have to be aware of while we are doing a bypassing for our instruments. Not to create, it is not logic to create another pass. So the infection is still in place. Not to speak from one side, also we have to speak what are also the limitations of retrieval. It is not that something the retrieval is the best case scenario and the bypass is the worst case scenario or the opposite. We have limitation for each treatment modality. One of the biggest major limitation complication is the weakening of tooth structure and sometimes making a stripping perforation, especially if we are not trained well. I will give you an example for a case that I did over instrumentation or removal of tooth structure because I wanted to remove a broken file. You will tell me, okay, Talal, why you are thinking of removing this fragment at the apical part? Why you just don't go for bypass? This case, this premolar was vital. Each time I remember this case, I feel pity on the patient because the patient was advised to do root canal treatment for both molar and premolar and to do a bridge. In sake of the bridge, they were vital. Nothing were in the molar, premolar, and the molar just they were killed in order to make a bridge. But during the instrumentation, the dentist broke a file at the apical area. He obturated everything. It looked nice on the X-ray. We have a white line reaching the very apical area, so we are happy. The patient came to me. Each time she bites on the premolar, she feels very severe pain, like something is pointing on her bone. I removed the gataperca and I attached the apex locator, and I found that once I touch the tip of the broken file, the apex locator will give me overextension. And you know all what is the meaning of this. This means that the broken file is overextended. So for me, if I have a broken file overextended, bypassing will minimize the amount of infection, but will not help the problem too much. So if we have an infection, so in this case, I try to remove it, but as you can see here, I obturate the apical part, I have to enlarge too much. I enlarged too much because I was attempting to remove a broken file at the apical area, and I told you why. And this is one of the limitations of the broken file removal. And another limitation, very important, is we need special training. We need special equipment. We need magnification. And after using magnification and ultrasonics, it's very important to train well on extracted tooth in order to be able to do it or to practice on your patient. So I don't advise to go immediately for patient. I advise to try and to rest. So this is of the limitation, but I believe that we can overcome. Like you can see now, I listed some drawbacks and some benefits for each one. and I will list how I'm dealing with the removal. It's not, we don't have time to speak all the techniques, but I will mention the ultrasonics technique. I mentioned it was when I did a presentation 1 week before with Zoomax about so many techniques, but here I will mention only the ultrasonic. Ultrasonic, when we want to remove a broken file, we have to create a straight line axis with a GG file to size 2 or 3. And by the way, the size of GG file 3 is 90, and the size of GG file 2 is 70. At the beginning of your trying to remove a broken file, you need to go for GG file 3 in order to have good flaring and for good vision to remove a broken file. But after you gain experience, you don't need to go more than Gates-Glidden size 2, which is 70. And we're going back to my dear friend, Dr. Hammo, when he was advising to make a coronal flaring before bypassing. And me too, I advise to do coronal flaring before bypassing, because it's very important for increasing the potential of bypass. We use one flare, like you saw, and we know that one flare has a 9% taper, and the tip reach up to 1 millimeter. So if we inserted the full one flare, we will be enlarging till 1 millimeter. So 70 or 90 will fall in the same. But the problem, what, my friends? The problem is we try to remove a broken file, but we are not trained well on the patient with indirect vision, so we enlarge too much in order to see. But if you train on extracted tooth, 10 teeth, not more than this, you will have the experience to go for to remove a broken file with your patient. And we use ultrasonics in order to vibrate and to remove a broken file. One of the ultrasonic devices I'm using is the D600 from Woodbaker. I can find it very good, very beneficial, especially that the endo function of it helped me a lot using the ultrasonic tips. One of the recently launched tips from Woodbaker also, we have the ED6. The ED6 ultrasonic tip, this is the shape of it. And I compared between this ED6 from DTE, Woodbaker, and ET25, the very famous tip from Satellite. And you can see that the ultrasonic tip in this area, it is much more narrower comparing with ET25. What do I mean by this? This will give you better visualization while you are trying to remove a broken file, but on the other hand, will give you less amount of power comparing with more amount of metal. So when you try to use, for example, if you set to work with 6 ultrasonic power, you go for 8 with ED6 to compensate for the minimum amount of metal you are using. I will end up with this clinical case. It was referred to me, we have a broken file lower second molar. I always keep measuring the file in terms of selecting the proper way of removing. We have 4 millimeters, more than 4 millimeters. I have 2% almost the broken file. And in the distal, we can see that the distal obturation is not well centered. So we may expect that we have additional anatomy in the distal. As you can see, after removing of the obturation, we see a lot of leakage. We remove everything. This is just to show you how much is the leakage is influencing. This is dye like a Cares indicator, and you can see the amount of leakage all around the obturation of the obturation. You understand that we have to retreat everything. And this is the mist canal in the distobuccal canal, and now I have to remove the broken file in the mesiobuccal canal. I enlarged with GG file size 2, size 3, and I exposed the broken file. My treatment plan was here. First, to use the ultrasonic to expose 1 millimeter of the broken file in order to catch the broken file and to remove it using the loop technique, because the broken file is long. When it's longer than 4%, I prefer, as recommended by Dr. Tirushi, to go with the loop technique, loop devices. So this is the exposed 1 millimeter. Here I am using the ED6 from Woodbaker. I'm trying here to drill all around the broken file 360 degrees. If you want to remove the broken file with ultrasonic only, you go from one side only semicircular. But if I want to expose the tip to remove it with a loop or any grasping technique, I have to drill 360 degrees. And now here I'm using the BTR loop. after engagement of the broken file, and I'm trying to make some movement, I was successful in removing the broken file and was removing my loop device ETI. You can see that I was able to expose only the 1 millimeter. Then I get it with the loop device and I remove it. And then, of course, I will keep putting this slides because the most important thing is to have the disinfection to clean our root canal. We will not be here, like Dr. Muhammad said, okay, we want only to remove a broken file. We want to remove a broken file or to bypass a broken file in order to gain more disinfection of our root canal. So don't forget the role of disinfection and activation after removing or after bypassing the broken file. And this is after removal, and this is the obturation. And you can appreciate that it is not too much to remove from the tooth structure. Again, if you practice removal of a broken file, you're gonna have the benefits of removal and minimize the potential. And at the end of my speech, as a conclusion, bypass is not the treatment for all cases. Removal is not the treatment for all cases. For me, I believe that as a dentist, we have to be familiar with both cases. But of course, I know not all dentists have microscopes, not all dentists have the training ability, but I believe in the coming days, people are going to learn more and more about these clinical techniques in order to get the best case scenario, which is the removal when it is indicated, and the bypass when it is indicated. And I believe every one of us, if he has a broken file in his tooth, he would prefer first to remove it than to bypass it. So I have to, I think it's good to adapt this also for our patients, taking into consideration all the precaution for bypass and all the precaution for removal as well. And thank you. Hope that you get benefits of this. My friend, Muhammad. Okay, you are muted. I can't hear you. Dr. Ali, I can't hear you. Alberto, okay.
Yes, thank you, Dr. Talal, for very, very nice presentation.
Thank you very much.
So now we have limited time. We have to make just quick questions for everyone. Okay, we select some questions. So Dr. Alberto, please, this question is projected to you. How to choose efficient rotary files from Dr. Sarah?
Today we have at disposal so many rotary files on the market. I think that the choice have to be done between the modern files, because the nickel titanium alloy has been evolved during these years. So we have at disposal new files with increased resistance to flexure, to fatigue, thanks to the new martensitic heat-treated alloys. So I think that the choice has to be done between the most modern files, because they are the result of the evolution of the metallurgic evolution and design evolution done in these 25-30 years of use of nickel titanium systems.
Okay. Another question, please. What do the type of rotation you prefer? The rotation or reciprocation, or to that which decrease the possibility of the fracture file?
Okay, honestly, I'm used to work with the continuous rotation. I always use it in my practice, continuous rotation files. Because I have been a little bit blocked in front of the totally reciprocating files. We studied in the last years in our university. We found some limitation in completely reciprocating motion because they can cause extrusion of debris and of bacteria over the apex. Today we have at disposal new motors that can balance the rotating motion and the reciprocating motion according to the stresses of the file. So it could be interesting to apply it to continuous rotation files, because on the market.
So just please, Dr. Alberto, is there something different in the endomotors, AI motor of Watchpicker? I hear there's an ATR movement. Can you tell us something about this movement of this type of rotation?
This kind of motors are made to reduce the stress, because traditionally a motor, when the motor find an increasing of the torque, is used to do a contra rotation and then restart to continue in continuous rotation. The ATR motors are made to balance the continuous rotation, but balance between continuous rotation and reciprocating motion when the file encounter some stresses or the torque is increasing. So it's an interesting solution.
Okay, thank you, Dr. Alberto, so much. I have to shift to Dr. Hammo. So there's some questions for you, please. When you are starting with the K files, asking if the files are nickel titanium or stainless steel.
It's stainless steel. No place for nickel titanium here. We need stiffer files to bypass.
Okay, there's another question. At rotary motion is why will you bend the K file, the size 10 K file? Make pre-bend.
The same idea, like I am bending the K file number 10, because if you place it in a straight line, you could not bypass. So you should pre-bend the K file. And nowadays we are using the controlled memory file, which are bendable also. So in case of bypass, you have to pre-bend your nickel titanium file.
Okay, but in the case of we got a sudden fracture file, what we have to tell the patient? How we can say it?
It depends.
It's very important.
It depends on your patient. So sometimes there are patients who could not accept presence of broken file inside. Legally, you have to inform him in a smart way. Smart way, that means we broke a file and we bypass it, and this will become part of the final obturation, and this not will affect the result. But frankly, for me, not all patients, I will inform them about the broken file, particularly if I can bypass it.
Okay, very nice. Thank you, Dr. Hammo.
Before shifting, can I ask me, Dr. Talal, one question?
Yes, you can.
Dr. Talal, I want to show you a case of you and tell me your opinion,
okay,
if you allow. Okay? Sorry.
Okay, my friend. Be gentle with me, my friend.
No, I want to fight. I want to fight.
Okay.
What do you think? Remove or bypass?
Yes, I remember this case very well. And this case, when I started negotiating, I put a treatment plan to bypass. This I did it maybe, I remember 4 or 5 years before. And when I told the patient, the parents of the patient, he came to me with his parents, and I told him, okay, this is an indication for bypass, especially for the mesial root, He told me, please, my son is going to travel abroad. I just remember every word that he was telling me. My son is travel abroad, and they send me to you because you will be able to remove it. I don't need you to bypass. He read a lot about this. He told me, please try to remove. I told him, as far as I will not remove too much from tooth structure, I will try to do my best in order to remove it. But I know that in such cases, you will remove more tooth structure in order to remove this broken file. But it was the insistence of the parent of the patient.
Okay. My question now, it's a simple question. Yes. If you have such a case now, you will bypass or remove?
For the distal, I will remove. For the mesial, I will bypass.
Okay. Do you want
I will
to
tell
show
you one. I will tell you what.
What is the consequences of removal?
I told you, Muhammad, at the beginning that consequences will remove tumor structure.
You know, I have one objection. If
Yes.
we want to remove, we will end with this. That means we remove a lot of tooth structure. And do you think this is not too much?
Yes, it's too much. It's done maybe, I told you, maybe 4 or 5 years before.
No, the distal
But
canal.
by the way,
You can see the distal
look for the
canal
recall.
here.
Sorry?
You can see here the distal canal.
Yes.
We removed a lot of tooth structure. You are excellent because you removed them, but unfortunately, we sacrifice a good amount of dentine, which means I think we have to a little bit stop insisting on bypassing, on removal, to go for the more for the bypassing, because we can preserve more dentine.
Yes.
Do you agree with me?
I agree to a certain limit. As I told you, it's a learning curve, dear Muhammad. You see now one clinical case, maybe I did it 1 year before. The last one I presented, maybe
I'm talking about the concept, Talal, not the case.
I totally, I'm also speaking about the concept, because the more you get trained well, the less you will remove a tooth structure. So now the question is, how much removal, to which degree removal will be considered risky? For example, I will give you an information. This case, this patient, I did it 5 years, and the patient is in the patient mouth with complete healing and no fracture in this tooth. Even though you see this, I don't have time. You just show the cases. I don't know. You will show this case. So,
no, but do you agree?
Can go for my records.
Nowadays,
and
we are
it's
seeing,
suffering, but it didn't fracture. Yes.
No, nowadays we are see more vertical root fractures rather than the previous. Why? Because many dentists, they are insisting to over prepare or use ultrasonic tips to prepare the canal. So I agree with you. You need a long learning curve to master the removal of the breakage of the file. But for general dentists, I advise them to go for bypassing. It's more conservative.
I totally agree with you, dear Dr. Muhammad. But maybe what is different in the concept between what I'm speaking and what you are speaking. If the dentist does not have the equipment, if the dentist, even if he has the equipment, but he didn't have the skills, he will stick to the bypass. But we don't have to say to our dentist, okay, we have a solution. This is 100% safe. Don't try to remove because you will remove too much tooth structure. But on the other hand, you ignore the possibility of breaking file while you are bypassing, the good disinfection of the root canal because you didn't enlarge well, or to the degree to allow for circulation. But on the other hand, bypassing is not 100% free procedure.
So let's reach to a middle solution. What yes. I advise my colleagues, at the coronal part where the dentine is thicker and it's easier, go and remove it. When you reach to the middle
just
part and the apical part,
just one thing, I disagree. Just one thing, go and remove it if you are trained well and if you have the microscope. Muhammad, you agree with me 20 years before. We were asking dentists, do you have X-ray machine in your clinic? Sometimes they will ask, yes, we have. Sometimes they don't have. Nowadays, you are pushing to get CBCT in the clinics. That's so right. After 10 years from now, I believe CBCT microscopes will be available in most of the clinics. So we are speaking about the future. I want to ask you a question, Muhammad, and please answer me honestly. If you have a broken file in your tooth and it is in the middle third, third, not the apical third, and it could be seen, would you choose bypass? Like a lot of your cases, you are bypassing in the corona or removal?
Frankly, I will choose bypass. Why? Because this way it will live longer than removing tooth structure. Talal, daily I see vertical root fracture in my clinics, and most of those vertical root fracture are due to malpractice. So till our dentists become like Talal, I will not rely on their experience.
Opposing, I'm very good. I do appreciate your compliment, but actually I believe, for me, if it comes to me, I believe that better debridement with skillful one.
When I come to your clinic, don't remove.
Will be able to disinfect the canal, which is the main core. So what is the meaning of having too much sufficient tooth structure with infection inside? This is also, it's a controversial issue. I'm not saying that you are wrong. I'm not saying that I am right, my dear friend, but we have to have something in the middle. I am pushing for everyone try to improve his skills in order to be able to remove it when it is indicated.
At the coronal part, yes, improve it. Down,
yes. Now, please, can we shift another question? Yes, Dr. Talal, we have questions for you, please. Dr. Talal, this is asking, is the ultrasonic device you are using is the same as the scaling device, or there's a special scalar, ultrasonic scalar from Woodpecker that use it with the removal?
No, at all. You don't have to use the ultrasonic tips with the ordinary scaler. You have to go for specific devices like I told you about the D600, but it's very important because the power settings and the type of movement is especially for endo. It's not good to use the ordinary scaler with endodontic tips because they will break and they will not give you the correct power. So, but very important,
okay.
I have to mention, when you use the D600, you have to use the ultrasonic tips from Woodpecker that start with D after the letter E. The letter E is for endodontics, but after the letter E, you must have the D, which refers for the DTE. But if you have, for example, 600 from Woodpecker, you can use the tip E, for example, 6 without the letter D, because the D600, the tips are compatible with DTE or satellite. The Woodpecker is compatible with EMS. So it's very important. If you apply ultrasonic tip with other devices, you will injure your device. Very important.
Okay. Another question. In one of your cases, the file is pushed apically. In like this situation, what's your treatment plan? How can you deal with this file which was past the periapical area?
In this case, we saw a case. Dr. Hammo was lucky in removing one was bypassing. And also I have cases, I was lucky again to remove it bypassing. But when I deal with such scenario, you will ask me, what do you do? It is in the
when you push it periapically, pushed, it's already pushed out of the tooth.
I don't advise to stay like this, because to a certain degree I can do it, but in very special circumstances. But if I see, like, if I speak like this, everyone is listening to me, maybe he will push a broken file to a nerve block, to a alveolar nerve, or to the sinus. I don't advise. We will try to remove it, but we will tell the patient, be aware that the attempt of removal is risky and it could be pushed. And I will not, never, ever try to remove it if I don't see the CBCT before and I know that I don't have any danger surrounding. Sometimes I will be lucky, sometimes no. If I was not lucky and the patient keep having symptoms, very important, after obturating the root canal, the patient keep having symptoms, we go for periapical surgery. And now we can do it under microscope and we can get very nice results. Otherwise, if we not be able to do surgery, the patient keep complaining, that is the role of extraction and implant instead.
Okay, please, I just have a personal question. In the case of the tooth is vital or non-vital, the treatment plan will be different or not?
Excuse
me?
If
the case is, if the canal, if the tooth is vital or non-vital, is the treatment plan will be different?
The potential in vital cases, if you are not able to bypass nor remove, the potential will be better in the long term, like the case was showed by Dr. Hammo. It was broken file at the apical area, but the case was vital. So, but on the other hand, if it is non-vital, the complication will be more. Okay.
Okay.
This is
at the period of the instrumentation, at the early instrumentation broken file, or after finishing all the instrumentation and the cleaning and good irrigation, then we got suddenly a fracture file. is the treatment plan will be different?
We learned in the university that, okay, sometimes if you have the broken file and you did instrument well and you did irrigate well, leave it at the working lengths and monitor. But actually, the broken file will have spaces all around. So if in terms of disinfection, we know that we cannot do 100% disinfection. We still have some microorganisms. But speaking in general, for general dentists, they can do like this and they will monitor the results, or otherwise they will try to refer it for endodontist or try to bypass.
Okay, before the finishing,
you are laughing, Muhammad. I have a question for you because you list one of my cases, but I didn't prepare myself, but I keep following your cases. I keep following your cases.
Surprise you.
Okay, you teased me. Okay, no problem. But I will tell you something. I went back to your Instagram account and I advise all of you to follow Dr. Muhammad Instagram account as well as my account. It's very nice because no social events in the Muhammad account, so you can see all the cases. Okay, very nice. You can have an idea about different, and you keep saying Muhammad, bypass is a conservative, bypass is a choice, bypass is a decision, whatever. I noticed very important thing, and please, I want an answer from your side.
Yes.
About 90% of the cases you go for bypass, even coronally, even in the middle part, they are 2% files. They are K files, and I believe bypassing a canal with a 2% file is much more easier than 6% or 4%. Do you believe that there will be a difference if you have a broken file, larger broken file, in terms of bypassing compared with a canal with 2% K file or barbed approach or lentulo?
If the broken file is 6%, it's more difficult, absolutely. But
so we go for removal
inside the canal.
Let me tell you, Talal, something. Sometimes, if I have two canals and they are joining and with one exit, and I could not bypass it, I will leave it and I will go with the other canal and fill it. And I have several cases with follow-up, and they are successful. What I'm emphasizing at this time, please, let's be more conservative and let's not sacrifice precious dentine, particularly, as you said, if you don't have microscope, if you don't have special tools, if you are not trained well, don't jump to just I attended the Talal course and I will go to remove the broken instrument. We will.
So you mean me by that post? You meant me by that post, Muhammad? You meant me by that post. I catch you red-handed.
No, clean-handed. You know, I admire you are doing your best to inform the dentist about let's keep the teeth and don't remove them by teaching them how to remove. But what I want to emphasize, this is a long learning curve, not one, not two, not three. You need a good experience. As you said before, after 5 years, now your decision might be different. You will not go to remove every file. You have to think better about the remaining dentine.
Let me add something, my friend. Ali, let me add something, my friend. Also, on the other hand, you want to emphasize about the importance of tooth structure and totally believe that the more the tooth structure, the more the surface of the tooth into the root, onto the mouth. But also we don't have to ignore the importance also of debridement, obturation, and disinfection, which is sometimes prevented well by bypassing technique. So we have to be in the middle way between you and between me in order to make a compromise, not to focus only about the tooth structure, forgetting about disinfectant. Alberto, you wanted to ask me something? Sorry, I interrupted you.
No, it's okay. I was only referring to the case with the apical extrusion of the file, but I just think that in cases like this, the first choice after extrusion of the file is not directly program apical surgery, but we have to follow up the tooth to consider the symptoms and the signs of the patient. In fact, if I remember, you put the follow up after 7 years, yes. Right? Yes. And in that case, the tooth survive without any apical surgery.
Okay.
Okay. Thank you, Dr. Alberto. Thank you, Dr. Hammo. Thank you, Dr. Talal Nahlawi. I think it was a very, very nice meeting, very informative. All of you gave us very good informations, but I hope we get more webinars like this and to get a better fight. I really hope to get a more fights between Dr. Talal Nahlawi and Dr. Muhammad Hammo. And it's not so hard.
Especially now.
No, I not more. I know more.
Fasting. Okay, Ramadan. We try to be
Ramadan.
angels. Angels.
Yes. After Ramadan, it will be more hot. I hope so.
My dear friend Talal.
Thank you very much. Really, I enjoyed speaking to you, my friend.
Thank you, Talal.
Okay. Now we have to
safe in your clinic, and all of you be safe, please.
Okay. I hope everyone around the world to be safe from coronavirus. Please stay at home. And thank you, speaker, for this opportunity and to gather like this very, very famous with the, very nice informations around all the world. Thank you, everybody. Go to eat, Dr. Talal. It's the time, I think, for eating.
Yes. Still have 15 minutes.
Yes. We say Assalamu alaikum, fi ma'allah. Bye.
Bye. Thank you, Woodbaker. Thank you, Woodbaker, for this nice opportunity.
Thank you.
Thank you, Vicky. See you soon, Quella.
Bye. Thank you.
Bye, Muhammad.
Thank you.
Hope to see you soon. Bye.
Thank you all.
Thank you.
خلص بابا يلا خذ يا رب.
Bye. Take care.